So welcome back, everyone.
Hello.
Hello. As some of you will know, Dr. Vanessa Sarkozy is a head of department and a developmental paediatrician at Sydney Children's Hospital. Her area of expertise is in the surveillance, screening and diagnosis of children with suspected delays or disorders in development, what are known as neurodevelopmental disorders. She's interested in optimising access to early intervention, getting in there as soon as you can, and giving support for children and families. And she and her colleagues provide counselling, advice, information and support for families and children who have a developmental delay or disorder. Many of those who are in New South Wales will probably have met Vanessa. She has extensive experience of working with children and families affected by TSC. And tonight she's going to talk about identifying and assessing neurodevelopmental disorders in children with TSC, the role of early intervention and support, how to get support through the NDIS or community services, and also point us in the way of some useful resources. As Rob said, there'll be a couple of chances to go into small breakout groups during Vanessa's presentation. And we do understand that this topic can be quite confronting, so please make yourself comfortable in whatever way you can. I'd also like to extend an extra special thanks to Vanessa, because she's actually on holiday with her family in Vincentia at the moment on the south coast of New South Wales, and has taken time out from her holiday to join us. So thank you so much, Vanessa, and welcome. And everyone, I hope you really enjoy and get a lot out of Vanessa's presentation.
Thank you. That's a lovely welcome. Yes, I must look at my diary more closely. But the internet here is better than it is at home, so it's good. I think I would have had to do this on my phone at home. And I'm going to talk to you tonight, as we've said, about neurodevelopmental disorders and TS, and really just about typical development, when we worry and what we can do about it as we go along. So I'm a developmental paediatrician, which is an interesting part of paediatrics. Doesn't exist in adult medicine. So our job in the broader umbrella is community child health. So we're interested in optimising outcomes for children who are not sick. Generally. So we look at children with developmental difficulties, child protection's in there, vulnerable populations, so refugees, etc. So that's the population we look at. And we have quite a long lens in terms of being interested in thinking about where the child's going to be an adult and what we can do now to make that as good as it can be for each individual child. The plan, if I can keep to time, is really to talk briefly about neurodevelopmental disorders in TS, but really briefly just to describe the situation that many of you would be very aware of now, talking about what typical development looks like and how we watch it, and what is developmental delay and how that's defined and what it means. Then we're going to have the first breakout to really discuss that, and then come back to talk about screening, surveillance and assessment of what that means and how it works, with a focus on New South Wales, although these systems exist in all of the states and territories. Then another breakout, and then finally really a discussion about early intervention. It is a huge topic, which I discovered when I tried to put all the slides together, so I am going to skate across them, but very happy to answer questions and discuss in more detail, or come back and do it again with other aspects of the topic that I won't get to tonight. TSC is associated with a broad range of neurodevelopmental and psychiatric outcomes, which you would all be aware of, but they're incredibly broad and very different. And one of the big frustrations, I think, for families, particularly of children diagnosed either antenatally or in the first year of life, is that we're not very good yet at being able to predict what the outcome is for each individual child. In fact, we're terrible at it. So my job is very much goes back to that surveillance, screening, assessment, thinking about in terms of what are the issues for this child, which could be completely different to the child I see next, and how do we support that individual child? Because there's no one TS response, because each child will be completely different and have very different needs, and it's inappropriate to have one system for everybody, and it is about responding to the individual needs of the child. So as we'll talk about, developmental delay and then intellectual disability is common in TS, so probably about 40% of the population that we look after. Autism is also common, so we see it about a third of children with TSC. ADHD is really common, so we see that up to about 70% of the population, depending on which paper you look at. Memory and executive function is an issue that is harder to diagnose, and we tend to see that in older children and adults, but only if we look carefully for it, and often accessing those assessments are really tricky. And then specific learning disorders. So that is, it's what we used to call dyslexia or dysgraphia. It's the latest iteration in the newest DSM-5. It speaks to a gap between your cognitive potential, so where you should be based on your IQ, and difficulties with learning, as opposed to having a cognitive difficulty, which makes learning difficult. So that there's sort of a subtle difference, but management is different, and support is very different, and assessment is different. And that's a disorder that we would not diagnose until someone was at school and trying to learn academic content, essentially. But as we said, each individual is incredibly different, and that's why we need to tailor assessment, advice, and intervention to the individual child, not to the disorder. This is an old graph now, so it goes back to 2007 and looking at cognitive abilities of the whole TS population. So the dotted line is the whole population TS, everybody in together, and that's a normal distribution, which means that you've got a fairly symmetrical lump around the middle point. So average IQ is 100. Most people sit in the average range, which would be 80 to 120. And then we've got some people who sit at the high end, and some people who sit into the borderline and their disability range. We talk about disability for those people with a cognitive ability of less than 70, although increasingly we talk about it in terms of adaptive function rather than just a number where you are on a cognitive assessment. Most of the TS population mirrors the general population, but just slightly shifted to the left. But we have a proportion, probably about 30% on newer data, who have got a significant intellectual disability. So how do we look at children, and why do we care about children's development? It's an incredibly complicated time. I think it's fascinating what we expect and achieve for children in those first 4 to 5 years of life. So we go from being entirely helpless at birth. So we have no capacity to communicate, we can't feed ourselves, can't move, can't even hold up our heads. And by the time those children who are typically developing hit school, they are able to articulate their needs, their wants, they can talk about abstract ideas, they're able to run, jump, skip, climb, they can hold a pen, should be drawing, opening a lunchbox, toilet trained. So the expectations for those 5 years, there's no other period in our lives where we would expect anyone to gain that degree of skills. I mean, so a uni is nothing compared to those first 5 years of life, because it's incredibly intense. But I think what's important is to understand that it's just not just about the child, but it's about the child and how the child interacts with the environment around them. So, and that's what we can do. We can't change the child, but we can do a lot to optimize the environment and that interaction between the child and the environment to optimize that child's long-term outcome. And we see that from lots of studies, sadly, and neglect often, that if we don't have a good environment for the child, it impacts their early development and their long-term outcomes. So that, I mean, the really big studies were done, a lot of those Romanian orphans that we met in the 90s. And we can do a lot to make the environment as good as we can make it to optimize that child's development forward. There we go. So when we talk about development, we talk about 4 main areas. We talk about gross motor, we talk about fine motor, communication, and personal social. So what we mean by those terms is that gross motor is the big movements. It's the sitting, the standing, the running, the jumping, the skipping, the riding a bicycle. The fine motor is much more the hand-eye coordination. And we go from being a baby with that sort of hand regard that we're interested in, to then being able to grasp, to transfer, to self-feed, to draw, and move forward. And again, that's a fairly complicated process that requires both use of coordination of your fingers, but also vision. So it's quite an integrated and complex set of conditions to be able to move those things forward. Communication is understanding spoken language, using spoken language, and non-verbal skills, including gestures, so pointing, waving, using language. And we really move through from that, just being able to start to respond to sounds, to attune to it, to non-vowel sounds, to babbling, which are vowel sounds, consonants, combinations, to words, and then into complex sentences, both using and understanding, and then using language to understand really abstract concepts, which sort of sets us up for learning to read and write as we go forward from there. And personal social is both the ability to look after yourself, but also to manage yourself in community. So that includes play, and it includes socialization, engaging with peers and engaging with adults, and monitoring your behavior and interaction with the environment. So this is a really old slide, which I nicked over a very long time ago from another doctor, but I really love the way it sort of articulates that progression in terms of skill development. So child development is building one skill on another, and we need to acquire each of those skills to move forward. So clearly we can't roll until we have head control. We can't sit until we've got control of our torsos, and we can't stand until we've got really solid control of our torsos and a capacity to move our legs and coordinate and balance. So we need to sort of move through that system. The ages which we move through, some skills have got really short ranges that are normal, and some have got a really, really broad. So we expect head control by 6 weeks, but walking is normal, anything from 10 months to 18 months. So each of the skills have got a different timeline around them, but it's the sequence that is hardwired really, because you need to be building one on top of the other as you go forward. Okay, so developmental delay is a term we use only for children 0 to 5. Lots of people use it older children, but it's not correct. And it's important that when we're able to use more definitive terms, that we use them, because they're more meaningful, both in terms of the family, in terms of planning, prognosis, and to the individuals working with the family. So developmental delay is a failure to develop skills in the expected time frame. And we can talk about delay being confined to one area, or we can talk about it being confined to lots of areas. So if you've just got language issues, we'd say you've got language delay. If you had language issues, difficulties with fine motor, problem solving, so those cognitively loaded scales, we'd be starting to talk about a global developmental delay. So it's an issue that applies across a broad range of developmental areas. These are what we call the flags, or the things that we feel that, certainly this is what I hammer into my med students. These are the skills that can alert us to problems that are coming along, because these are the milestones we expect children to meet. So children should not go backwards, and we see it with seizures, but it's always something that we should be responding to. Children should be rolling backwards and forwards by 6 months. They should be sitting by 8. They should be crawling by 10. It doesn't matter if it's commando or not. Commando is a very efficient way to get around, and children who learn to do commando crawl well have no incentive to go to the next stage. And that's development is for a purpose. It's a skill set. We go from crawling to standing because the view is better. Not generally because we can move faster, because little E's that can crawl can go, and commando crawl they can zip off. But it's really hard to crawl and look where you're going. So there's an imperative, a developmental imperative to standing. Children by 12 months is a big milestone in terms of early childhood. So we expect children to be babbling. So that's making a combination of consonants and vowel sounds, ma, ma, ba, ma, 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 da, 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 da. Or a combination of what we call variegated babble. So that's when you, sorry, I knew that was coming, where we mix sounds, so magoo or daba, that sort of variegated shape that we start to see around that period of time. We expect children to start to use gestures, including pointing, and that's one of those things we're particularly interested in, because that speaks to sharing communication. And pointing is important because it's where we develop our ability to learn vocabulary, really. So that's why the 12-month-old typically sits in a pram and goes, da, and you go, plane, you go, da, and you go, dog, da, man. And that's really how you're matching. You're both looking at this item and you're labeling it. And that's how you develop that richness of language, by sort of pointing to something and showing. And that's why not pointing is always a worry, because it demonstrates a lack of understanding that this adult can give you information, that communication is a two-way thing, and it also impacts on your capacity to learn vocabulary in many ways, because you're not looking necessarily at the thing that the other person's trying to show you. Other gestures that we expect to see around 12 months are no, no always comes before yes. Putting our hands up usually happens about 6 months typically. Blowing kisses, waving, those are the sorts of gestures that we're starting to. You get a lot of non-verbal communication before you get verbal communication generally. And we expect children to know their name by 12 months. So not just respond to being called, which is a 6 to 8 months skill, but to recognise their name. We expect them to be using language, at least single words, by 16 months, and putting 2 words together by 24 months, so 2 years. So what I mean by 2 words is 2 novel words. So more juice, daddy car, let's go, rather than bye-bye or high five, which are sort of learned as chunks because it almost becomes just a word. And we would typically expect children to be walking independently. Surveillance, screening, and assessment. She said a rapid talk through. So these are technical terms that come from the American Academy of Pediatrics, but I think it's worth knowing what we mean when we're talking about this stuff. So surveillance is the idea that everybody interacts with the child, the early childhood worker, the parents, the speechy, the PED, the GP is watching and being aware of any vulnerability, which we'll talk about in a minute. And acting on it, whereas screening is actually using a tool of some description. An evaluation, which we would call assessment, is the final process of coming up with a diagnosis, or yes, no, developmental level, etc. So that's how I envisage it. So universal surveillance is the system where all children are screened for development regardless of risk. Screening is the next level if there are any difficulties identified through that universal surveillance, and assessment is that definitive, and it's just the top of the pyramid, and it's only a small number of children will need that, but it's that's how the system is supposed to work. I think, an animated slide. In New South Wales, this is the system that currently exists, but it will be, there is a system in all of the different states. Victoria have a very well established early childhood system. Brisbane have a red book, for example. Queensland have a red book. You know, each of the states and territories has a system, but the idea is that all children are screened routinely in early childhood for developmental difficulties. In New South Wales, we use the Blue Book. And the screening points are there: 6, 12, 18 months, 2 years, 3 years, and 4 years. The screening is run by early childhood nurses. It's a free service to everybody, and I don't even think they ask for a Medicare card, so even those that have got access issues for other reasons can move through the system. The idea is that you have a discussion with the early childhood nurse. They're currently using this system, which is, there's some websites for this later on, but this is Know the Signs Act Early. It comes out of the US. It's the CDC system, and it's about making families aware of developmental milestones and having a discussion, you know, is your child meeting the milestones now they're 12 months, or they're 18 months, or they're 2 years? And if there is a difficulty with those milestones, then they send them on to the next level. So in the eastern suburbs of Sydney, that's us, we look after the northern sector of that area. There's a community system that would assist with doing some screening. The early childhood nurses would be asked to do a test called the ASQ, which is the ages and stages, and then they pass on to the hospital and we do the next stage. In most other areas, the next stage is a paediatric review, and then the diagnostic and assessment services sit at the top of that pyramid, yeah, there at the very top. So what do I mean by an assessment? So what happens in the top of that pyramid? It really depends on what you need. And again, it should be individualized to the child. We can look at specific developmental difficulties. So if you presented with language delay and you went to see a speech pathologist, they would do an assessment of your speech and language, and that would be a specific set of assessments around your development. If there's a broader concern, then we would do a global assessment of development. So that's what my service would do. And we would use a tool called Griffiths, which is a developmental tool, but other services would use a Bailey's or a Mullins. It's basically a standard, a normed test that allows you to interact with the child in a standardized way and be able to say that the skills that you saw today, which may not be everything the child can do, and usually isn't, but it gives you a good feel for where the child's at, and you can then compare that to your norms and say this little person is got skills in their language development at the 2-year mark, or their fine motor at the 3-year mark, and it just really gives you an idea of where that child has achieved at that point in time. We tend to use developmental assessments, so an assessment of the things you can do, building blocks, drawing pictures, threading beads, answering questions until you're about 4, and then we talked about intellectual functioning. So that's when the IQ tests come in. So we would do a WIPC most commonly. Stanford Binet is the other name that you might hear about. Those require a minimum level of language, and they're not appropriate for all children. So to do a WIPC, for example, which is the one we would use for preschoolers, you need to have a language at about 2 years, 7-month level to be able to manage that test because of the amount of language it requires. That will tell us what your IQ is, which brings us back to those pictures I showed you at the beginning in terms of the distribution of cognitive ability. That would give us a number, so you've got an IQ, and it's always a range because obviously no test is perfect and we have to have a range. But we would say, you know, this child's IQ is sort of in this 55 to 70, so they've got an intellectual disability, and then we would look at the functional skills. So what's the child doing in everyday life, and how much are they limited or impaired by their cognitive abilities? And that's really where we start to talk about mild, moderate, severe, because we talk about it in terms of what you can actually do, as opposed to previously where it was just on your cognitive ability. And the fact is, individuals with the same cognition can have very different skills, and ultimately how you function and what you need to be supported is dependent on what you can do, not so much what the number of your IQ is. The next sort of set of assessments we would think about doing would be behavioural assessments. So this is where the questions of things like autism come in, or ADHD. So we can do specific assessments with the child, like an ADOS or something many people would have heard about. So that's an autism diagnostic observational schedule. But again, it's just a way of interacting with the child in a structured way that gives you a really good feel for their skill sets. And it's, I mean, the ADOS is particularly looking at your social communication skills. Other ways we look at behaviour often with questionnaires. So ADHD, the Conners would possibly be the most commonly used. Anxiety, we would look at something like the SPENS. So there's lots of different ways of gathering information, and often we want information from more than one source. So we want to know what's happening at childcare or at school, as well as at home, to give us that sort of broader picture. Learning and academic development assessments, those are done in school-age children, and they're sort of beyond the scope of what we're talking about today. But I think they're an important set of assessments which are hard to get to, and I'm happy to come and talk about those on another occasion. The system is set up really in an understanding that health looks after your development really till you go to school, and then once you go to school, school counsellors are supposed to look after you. And that is a tricky, because school counsellors are notoriously underfunded, there's not a lot of them, and they can often be difficult to get those assessments, but there are other ways of getting those as well. Yeah. So these came out in 2005. These are the consensus guidelines about when we thought children, or they thought children with TS should be reviewed, and they make sense at the beginning, the toddler years, before you go to school, in the middle school years, which is really where we think cognition is pretty stable at that stage. So your IQ is probably the same now as it was when you were 8, but your knowledge isn't. So it's not that your knowledge, you keep learning, but your ability to learn is pretty much, we can measure that fairly accurately by the time you're in those middle year schools. Then that transition into adolescence, and then adult follow-up. No service that I'm aware of in the UK or in Australia would offer this routinely, and I think that is a problem. But outside of a study, it's very hard to get assessments that are not problem orientated. So we don't do them because we know that you've got a risk because of TS, and we do them to understand so we can get in early and do everything we could possibly do to optimize long-term outcome. The services are rationed in such a way, and because it's a health focus, it tends to be accessing the services is very much about defining a problem. So there has to be a problem to get in, which is why I feel looking for it is so important. And I guess one of the really good ways of looking for difficulties is the TAND checklist, which I'm sure you're all familiar with. So this was developed later on, and this was looking at really a review of developmental difficulties, behavioural challenges, stresses on families, etc. And it's just a way of really trying to get a quick way of having a feel for what's happening at the moment for the child, the family, and the adult as well. And it's a nice screening, a conversation really in terms of knowing what the issues are currently that allows us in. These are the consensus guidelines that came out later. So these came out in 2013, I think these were published. And again, have really detailed discussion about what sort of assessments would be useful, but again, would be really difficult to access in the public health system unless that you could describe a difficulty to access those. But I thought you should have them, so I've put them in. And I think finally, this is an important point, that a lot of the assessments we do are deficit-based, so we're interested in what children can't do because we want to understand how we can best support them and move them forward, where they need intervention, where they need more help, and they can feel quite negative and sort of deficit-focused. And it's really important that no test is ever going to describe a child or any person actually, and that there's all sorts of other skills that sit well outside of our understanding of cognition, which is really talking about academic functioning, particularly once we get into the school setting, and that there's a lot more to being a person and a family member than your IQ and your functional skills. And I think it's important for us who do the assessments to remember that when we're communicating that with families. So we're interested in looking at children's development to identify difficulties because we believe we can intervene and provide support. It's also important for us as a flag for other problems. So there are, for example, if you presented with a developmental delay rather than seizures or antenatally, TS is one of the things we look for, amongst lots of other things, and it's an important diagnosis to make, as are many others that present with developmental difficulties. Understanding a child's need is a way of supporting the family, both in terms of their understanding of the child, but also in terms of them accessing the system and accessing funding. And depending on what diagnosis we find, it does help us give families more information about their choices and thoughts about other further family members. A term that we talk about a lot now, developmental vulnerability. So that's being at risk of having developmental, behavioural, neurodevelopmental, neuropsychiatric disorders as you go forward, and what we, as those of us who are interested in little people, can do about it going forward. And that can be due to genetic factors, for example, TSC. It can be many other medical disorders, really bad asthma, lots of admissions to hospital, lots of time in ICU, heart surgery, etc. All of those things can have an impact on your development. And then there's a whole range of psychosocial factors that are family factors that can impact on children and their development going forward. Developmental vulnerability as we go into school is actually really common. So this is a survey that all 5-year-olds get to do every 3 years. So the kids going into school every 3 years get an assessment by their teacher, their first teacher, as they start in their January, February, at the beginning of every 3-year cycle, and it gives us information about how ready kids are for school, and it looks at the 5 areas of development. And depending on how you measure it, and certainly the ADEC, which is this one, the Australian Early Development Index, I had to write it down because I knew I'd forget, tells us that up to about 25% of children will be developmentally not ready for school, and that can be, all the obvious risk factors are there. So whether or not you have English as your first language, whether you live in a big city or whether you live more further out, and if we compare children from the highest income bracket, the top 20% to the bottom 20%, and developmental vulnerability feeds through all of that, which is why developmental assessment beyond TSC is really important to all of us. And also those children who have one developmental vulnerability can have more than one, and I guess that comes back to those of us who are watching children and their development. Why do we really want to know about these kids before they've got to school? It's because we know we can make changes. So little brains have got what we call plasticity, so the ability to learn and change. We know we have periods in our development which we call critical periods, which are really important not to miss, which I'll talk about in a minute. We want to prevent additional difficulties from developing for individual children. So, you know, developing challenging behaviours, for example, because you're struggling to communicate and it's frustrating. We want to optimise the child and the family's outcome, and we want to provide the right supports to families going forward. Now, I'm not saying all of that actually happens, but that is the rationale behind why we do early childhood screening. These sensitive periods are periods in the developmental pathway where if you miss the boat, it can make it much harder to be able to get those skills later on. And I think I've got a diagram that speaks to that better. Yeah. So, for example, I think the easiest one to talk about is actually hearing, so central auditory systems. So we know that for the first 6 months of life, we start to lay down something called phonemes, which is how we understand sound and how we hear sound, which later translates to reading and spelling. We know that the reason we screen newborns for hearing loss is because if we don't, we want to find it really early, because you want to get a cochlea in by 6 months. So that second half of the first year of life, which is your critical period in terms of hearing, you've got normal hearing, so you'll be able to develop normal speech and language, and it's reading and writing, etc. So we're talking about that second period of the first 12 months of life, so 6 to 12 months is when we lay down our phonemes. And that's why when you meet babies, 6 months old will sound the same. Doesn't matter where you go in the world, they will babble the same. But by the time they're 12 months, they sound like they're talking whatever language they're growing up in. And it sounds like they're talking the language. They're not, because they haven't got the words, but they've got the cadence and the rhythms and the sound changes. And that's that second year of life. And that's why we screen for hearing at birth. The other thing that's is binocular vision. So that's why we worry about squints, because we know that if you've got a squint when you're really little, you get double vision. And the brain doesn't like it, so it switches off one of the eyes. And if you're not getting visual input into the eye, that eye doesn't develop, so you don't develop vision as well in that eye. And there's really not a lot we can do about it by the time you're 8. So squints are one of those things that we're always looking out for, because it's fixable, and then you can sort out vision. That's why we patch, we make the lazy eye work, so that you get that eyes getting that environmental input to develop the best outcome for the eye. And I guess that's the rationale of all early intervention, is really about optimizing these periods. So optimizing outcomes. So we can't do an awful lot to change a child, but we can do a lot to optimize the protective factors around children and minimize risk factors. So this is on a population level. You'd be talking about things like breastfeeding, you'd be talking about not smoking around children, you'd be talking about, supporting families, we'd be talking about preschool, early intervention, speech, OT, etc. So what we're trying to do is get the children to their potential by optimizing all of the things we can do around the edges to make it their environment and their opportunities as good as they can be, so that they can be the best person they can be going forward. And we know it works. So this is the Heckman graph. So he's a Nobel Prize winning economist. He didn't get the Nobel Prize for this work, but he got it for something else. But essentially, the time to invest money in your population is in the early childhood periods, because that's where you get the most money back. So we stop breaking even by the time we just get to schooling. So every dollar we invest in children under 5, we get a positive tax return for those that care about these things, and not so afterwards. So this is the optimal time to support children, all children, but children with TSC. Having identified that there's a difficulty, what do we do? So there's the universal interventions, and then there's the targeted interventions, much like the screening and assessment, really. So, and I'm doing this back to front because I thought this was probably more important. So these are the targeted assessment interventions. So this is what we do when there's a particular area of difficulty. So speech pathologists for speech, communication, verbal, non-verbal, play and social interaction, occupational therapists for fine motor movements, but also for self-care skills, daily living skills, and sometimes emotional regulations, bigger body movements, etc. Physiotherapists are much more about whole body movement, so gross motor, sitting, standing, walking, early childhood educators are focused on developing those early play skills, social interactions, and the pre-academic skills, cutting, pasting, gluing, all those things that you really need for school. Key workers are a way that some of the early intervention services work, where you just interact with one person, but they have all those other people behind them and they bring them in as needed. And psychologists, which I don't think I talked about enough in the early intervention period, so that 0 to 5, about behaviour, managing interactions and building skills for children around social skills and interactions with family members. The NDIS is legislated so that children under 7 go through the ECEI pathway, the Early Childhood Early Intervention pathway, and the children over 7 would go into what they call the full scheme. Now, the full scheme has qualifiers, so you need to have specific degrees of difficulties. It needs to be lifelong. But the under 7s, all children are essentially, anyone with any degree of delay is eligible for something from NDIS. And they can be either facilitators, so if you present and you've got just some speech delay and they don't think that they're the right service for you, their job is to link you in with community services, which are traditionally the people that work through hospitals or usually associated with health services, who primarily look after children who present with difficulties in one area, whereas ECI is much more about children who have difficulties in more than one area. So that sort of specific delay versus the global delay. So ECI, but if you have any concerns, ECEI is supposed to be your first port of contact. They're supposed to do an assessment. They'll do something called a PEDICAT. They'll take some information, and then their job is to link you into appropriate services and support based on your need, which needs to be reviewed over time. ECI partners and who that is will very much depend on who you live. So I've just copied out the New South Wales ones, but every state, again, if you go to the NDIS website, they will be able to direct you depending on where you live. And these do change because these are contracted out to agencies and they change over time, but these have been in for the last 2-3 years. The next important thing is early education. So the evidence is that between 3 and 5, early education, high quality early education is really important in terms of optimizing children's development, social interactions, their capacity to interact with others, adults and children, and to learn. It's a great environment to learn language and fine motor skills, toileting, because it's quite, having those peer models around you is really, really helpful in that age group. But the key to that sentence was about it being high quality. So there are some New South Wales Health funded ones, and again in every state and territory where there will be those that are funded, particularly for children with additional needs, and they're there to help move you into early childhood education if you've not already done that yourself. In terms of assessing quality, and I looked everywhere on the internet, this is an American website which talks about what does high quality preschool look like, and it's worth having a good look. It made sense to me in terms of what you were looking for when you walked in as a parent, as opposed to reading their reports. Or there is a curriculum, it is nationally validated, they are all assessed, but there's a difference, a quantifiable difference between a good childcare and a bad childcare, and I thought this website particularly had a lot of that really good information. These are the universal interventions, so this is about what all children should get to optimize their development, and that's why I put it at the end. In terms of understanding where children are at and how you can support them, this is the CDC, the Center for Disease Control and Prevention in the US. That's got some lovely apps. It's got some great ways of looking at child development. It talks about, in English or Spanish, positive parenting, and you can go through each of the age groups in terms of where your child's at and what you can be doing to support development and optimize it. That's sort of around managing behavior, but it's there for play and all sorts of things. It's a really lovely website. This is the Australian version, so this is the Love, Talk, Sing, Read, Play app, which again, you can download, it's free. You put in your child's date of birth and then it gives you developmentally useful information for that age range. But if you've got a child with developmental delay, what I would do is I'd just shift the age that you put in. So if you've got a 3-year-old whose skills are more like a 12-monther, then give them a 12-month age in the system, and that will give you, again, developmentally useful play activities and engagement with the child to enrich the environment that the child's living in. This is the Raising Children website, which is the Australian version. Again, lots of really useful information about all aspects of parenting and early childhood as well as older children, which I think is a really good source of information. So you can, this is all information about helping children with disabilities specifically, but there's also typically developing children. The whole range of information is there, and I've just particularly wanted to put this because it says it's resources for professionals, but it's for professionals to print off and hand out to parents, so might as well just call it resources for parents, really. This comes from the Royal Hospital in Melbourne, and Royal Children's Hospital, and it's an A to Z of behaviour management advice and recommendations. I've just copied the C page, but you can pretty much go to any one of those, and that's got really good evidence-based, useful information, which I think is really helpful. Yeah, any questions? So I'll race through the last bit, but I think the websites are all there.
But I think now, if anyone's got any questions, if they want to put them into chat or take themselves off mute and ask Vanessa any questions that they have around that wealth of information she has presented.
I'm happy to jump in. I was curious about how, as parents of kids with TS and potential developmental delays, how can we support daycares, child, any of those types of services? How can we help them best help our children? Any places to direct them to or recommendations? I
think developing a communication system between everyone who's working with your little person and childcare is really useful. We used to call it a communication book, essentially an exercise book. And this week the speech pathologist is working on X, Y, Z, and that's what you want to support them to practice, because early intervention is all about optimizing practice. So the more opportunities you have to work on that sign or that word or whatever it is in a real setting that's not just the therapist's room, the more likely you are to be able to develop that skill. It's just like, you're trying to learn anything. You're trying to learn the piano. You can do an hour with the piano teacher, but actually if you want to learn to play the piano, you need to go and practice for 2 hours every day or whatever. I don't play the piano. But probably, it's this practice that makes the difference. The tuition just guides you along the way. So that communication is important. I think putting services in touch with the TS Alliance in terms of providing written information around TS, because it's not a disorder many of them will have heard of. And I think if you've got seizures, the CNC epilepsy nurse who can provide information around managing seizures particularly, because I think that's what childcare centres often find quite daunting.
Thank you, that's awesome.
Vanessa, I've got a bit of a question. When you were talking about the sensitive periods for early development, in particular looking at the ones on peer and social skills and that sort of thing, Sammy's 2.5, but developmentally he's like a 7-month-old, and obviously we're getting to the end of those really critical sensitive periods. Are there things we can do? I mean, obviously he's so delayed that he can't participate much in those sort of activities and that sort of thing, so it makes it really tricky to maximise that potential now. Do you have any recommendations?
So you probably are doing all of this stuff already. So we do need to be developmentally appropriate to the child. So it's not about your chronological age, it's about your developmental level. So at 7 months, it's about socializing, it's about playing, it's about hearing music, it's about being around other children. All of that is really positive. He's hearing language, he's hearing simple language, because language is, obviously younger children use more simple language than us adults who use too many words at the time. He's watching play, he's hearing sounds, he's getting visual stimulus, all of which is really developmentally rich and optimizing that. But you can't put him in a 2.5-year-old environment in terms of the actual play, because that's not useful to him, but being around it is really useful.
Yeah. Okay.
They're not completely, I mean, it's a very simplistic graph, and I wouldn't take all those cutoffs, and the grey bit counts, as I was saying before. So for example, with the squint, the ophthalmologist will do surgery until you're 8. So, you know, it's a representation of the critical periods, and we try and optimize input during those ages, because you've got more opportunity to more easily take from it. But that doesn't mean we shouldn't stop those inputs when we get to the next stage. That makes sense.
Sorry, can I just follow on from that? So are you saying that, you know, for a 2.5-year-old whose developmental age is 7 months, that they should be playing with 2.5-year-olds? Like, you should be putting them with their chronological age or with their developmental age?
So I think for preschool placement, you need to be putting children as much as possible with their typically developing peers, because that's the environment that's most appropriate to the child. But you need to be supporting the child at the age that they're currently at. So I guess if we think of a 12-monther with 2.5-year-olds, he's more likely to be interested in stacking and posting and those sorts of toys. I wouldn't take those toys away. You just want the 2.5-year-olds to play with that child in
that way.
Does that make sense? So yeah. It's understanding where the child's at, so you're not making unreasonable expectations, but you're still surrounding them with all those other opportunities. And I think from a peer relationship point of view, it is really important that we support children where they're at with their peers.
Yeah, that's great. Thank you.
Any other questions that anyone wanted to ask Vanessa while we've got the opportunity?
Oh, hello. Yes, I was just going to ask, we're just in the push getting ready for school next year. But once we get there, how do we inform teachers of different assessments that need to happen, or?
So the teachers can't do standardized assessments other than academic assessments that they would routinely do. So any additional, for example, an updated IQ test or something like a WIAT, which is a test we look to give as a reading age and spelling age and things like that, the school counsellor would do within the school setting.
Right.
If you're in a it's much harder if you're in a Catholic school or another religious school or private school, because not all of those will have access to a school counsellor. There are ways of doing it, but
yes,
with the public system, the school counsellor is the person that does those assessments.
Right. Yeah. So we should be going to a Catholic school, but we're in Canberra, so it would be best just to approach the counsellor to maybe look at doing IQ tests then. Yeah.
Or doing it before they start, and then again in a couple of years' time.
And perhaps if it's before she starts school, then maybe through the paediatrician, their contact. Yeah.
So paediatricians can't do IQ tests. We're allowed to do a developmental test, but IQ tests you have to be a clinical psychologist to do. But they would be available either privately. Universities are often a really good source of clin psychs at an affordable price.
Okay, no worries. Thank you.
Got another question. Is there a way, without having it like professionally assessed, to kind of try and understand with a kid that has developmental delay whether issues are behavioral or if it's like a frustration caused by the delay and not being able to communicate? And I don't know if that's like a clear question.
No, it is. All behavior is communication. You know, whether it's a tantrum, there's always a reason, and the person that's having the tantrum thinks it's a completely rational way of providing that information to those around them. So, and the less language you have, the more informative behavior is. So behavior is always communicative. So there's always a reason for any behavior, whether it's a rational reason or not. It's, you know, a discussion you can have with your 2-year-old at any point. But that distinction between whether it's a behavior problem or whether it arises from the inability to communicate, I always feel like it's both. So it's a mechanism that's an effective mechanism often for communicating you know, something you like, something you don't like, something you want to do, not want to do. If you've not got language, then your behavior is how you let people know. And I guess that's where we see behaviors become entrenched, which are perhaps unhelpful. So it's fine to be frustrated and get upset and hit out when you don't want to do something, because it tells people, and it's an incredibly effective way, you know, if you're trying to do something, you're trying to feed them and they hit you, then you back off. That's, you know, normal. And it becomes quite entrenched, but it's not a useful behavior in terms of ultimately achieving what you want. So that's where behavior management comes in. It's not because the behavior is wrong or it's come from a misunderstood spot. It's just that that's ultimately not functional for the individual to communicate their needs.
Okay.
That makes sense?
Yeah. Yeah.
So most behavior management is about providing an alternative method of communicating your needs, wants, or what you don't want.
So is there a way of, or a direction as to where one should go to then figure that out?
That's where the ClinPsychs come in. And that's why I think they don't get talked about enough in early childhood, because people wait until the behavior is a problem before you get clinical psychology intervention in terms of understanding. So they're all about antecedents, so what causes the behaviors or precipitates the behaviors, and consequences, what they're getting out of the behavior. So, you know, if every time you scream and shout, people back off, then, you know, the precipitant is not wanting to do something, and the consequence is that you get what you want. Which continues to drive that behavior. And so that what they're then trying to do is give you other ways of managing that behavior, or that, you know, when you have that behavior, it doesn't give you the consequence that you wanted. So, I mean, if we think about typically developing 3-year-old, 4-year-old, 5-year-old at the counter at Woolies, and they want some lollies and they have a mega tantrum, and you're like, oh my God, just have the lollies, and then stop shouting and everybody looking at me. The next time you go in, if they want lollies, that worked really well last time. And they'll just have a bigger tantrum if you say no. So what you're doing is reinforcing the behavior, which is negative, obviously, for you and the child in the longer term. And that's what psychologists do. They analyze behavior and they look at what causes and effects are. Now, there are behaviors that happen for other reasons. So we see behaviors in autism because you're just sensory input, or, you know, an unexpected change, and that all needs to be looked at as well. And developmental peds can do that, general peds can do that, psychologists can do that. But really understanding what's driving behavior and changing behavior to become more functional is the job of a ClinPsych, and I think we underuse them in the littlies.
Can you use a ClinPsych when your child is nonverbal?
Yes.
Right.
So obviously they won't be doing CBT, because, but they can, well, like all the other therapists, they'll be working with the parents.
Okay.
So they do. Yeah.
I think we better call a wrap there. Thank you so much, Vanessa. Thank you everyone for joining us this evening. Rob, if you could put up a quick poll, it'd be great to get some anonymous feedback, and I will go out with an email just asking everyone for more feedback on tonight's session. But yeah, look, thank you all for joining us. I'm sure you all got something out of that. It was really incredibly informative, and thank you, Vanessa. Can't thank you enough for joining us. And I think we've probably got another 3 or 4 sessions for you to do based on all the different things that have come up tonight. And thank you, Rob, for your help as usual. We really appreciate it. It's fantastic. And hopefully we'll see you all again soon, and we'll get the recording of this session, the slides out to you. And if you've got any other feedback for us, we'd love to hear it. So thanks everyone for joining us tonight. Enjoy the rest of your evening.